Assalamu alaikum everyone, my name is Khaled Hammoudeh and I'm going to be talking about cardiac output 1. This lecture was long and dense, however, it's not a hard lecture, it's an easy lecture if anything, and I try simplifying it as much as I can. Okay, now, before I start talking about everything, the doctor basically broke this down into nervous regulation and local regulation. Most important aspect is the nervous regulation, which was talked about the most. And in here he mentioned these 3 points, and these all are going to make more sense later on in the lecture. Nervous regulation does adjusting the blood flow distribution to various regions of the body, modulating the heart rate's pumping strength and rate, quick regulation of systemic arterial blood pressure. Now, the most thing that we're going to talk about here is arterial pressure. You need to understand how does arterial pressure work, and you need to know its equation. Arterial pressure's equation is cardiac output multiplied by total peripheral resistance. And you need to know these 3 things that increases arterial pressure. Constricting most of the arteriole, and if we constrict the arteriole, our TPR is going to increase. And constricting veins, however, is going to increase our venous return and cardiac output. And obviously, increasing heart rate is going to increase our cardiac output. These two I'm going to explain in this image. So, obviously, this is a sympathetic response. This is not a parasympathetic response. We're going to talk about the parasympathetic response after. So, in the sympathetic response, if we constrict our arteries or arterioles, our resistance is going to increase. And from the equation, we know an increase of resistance, or TPR, is going to increase our AP, arterial pressure. And an increase, a constriction of the veins is going to increase our venous return. And obviously, increase of venous return increases our cardiac output. Increasing the cardiac output is going to then increase our arterial pressure. You can also see in the image, vasoconstriction of arteries leads to increase of resistance, and the increasing of veins is going to increase our venous return. Now, parasympathetic. Parasympathetic, opposite of sympathetic. Instead of increasing heart rate and increasing its cardiac contraction, is going to decrease. And how does it decrease it? It's all the parasympathetic activities to the heart happens via the vagus nerve. Now, I'll put the slide again for the sake of repetition, because to emphasize how important these 3 you need to know. These 3 are really important, and they were also repeated multiple times in the lecture. I also added a note that sympathetic increases blood pressure by 2 times within 5 to 10 seconds, so it acts faster. So sympathetic is faster than the parasympathetic. Parasympathetic increases blood pressure by half, which means it's going to decrease our blood pressure by 2 times within 10 to 40 seconds. Now, I added a question here to test your understanding so far. A sudden drop in arterial pressure triggers several compensatory mechanisms. Which of the following responses would help restore arterial pressure to normal? From the 3 things that we mentioned, one of them is only here mentioned, which is B, constriction of large veins to increase venous return. Okay. Now, we're going to talk about baroreceptors. Baroreceptors is an important concept. So, we have 2 types of baroreceptors: high pressure receptors and low pressure receptors. High pressure receptors are in the carotid sinus, aortic arch, and renal efferent arteriole. However, you only need to know the first 2. Low pressure receptors are found in the right atrium. Right atrium is mentioned twice here. I don't know why. And pulmonary artery. These 2 you can find low pressure baroreceptors. Basically, high pressure receptors are going to act when we have high pressure. It needs to be compensated. We need our pressure to be less. So the baroreceptors in these locations are going to act. And low pressure receptors is going to do the opposite. It's going to be explained more after, but I basically explained what it is like overall. So, baroreceptors in the aortic arch and the carotid artery, okay, they consist of a spray-type nerve ending. Now, if you don't understand what the spray-type mean, spray-type nerve ending, that means that they spread out. Like in the atrium, for example, they're spread out. Not in the atrium, I'm sorry, in the aortic arch and the carotid, they spray out. So if they sense any type of stretch, that means our arterial pressure is high. And once it senses that, it's going to send signals to the medulla oblongata and is going to then activate parasympathetic activity. The pathways, you need to know which nerve is for each one. So for example, the aortic arch, it's going to move via the vagus nerve. And the carotid sinus is going to move via Hernig's nerve or glossopharyngeal nerve. You need to know these two, these are important. Now, actually here, let me explain to you on this image. So, as you can see here, we have the nerves, the baroreceptors at the carotid. So, once they feel any stretch or an increase, if there's any sensation of an increase of arterial pressure, is going to send signals to the medulla oblongata via the glossopharyngeal nerve, because it's the carotid. If it was the aortic arch, it was going to be the vagus nerve. And then after it sends this signal to the medulla oblongata, it's going to then send parasympathetic activities to decrease the contractility of the heart. Okay. Also, we need to know the differences between carotid and aortic arch. We mentioned earlier one difference, which was the nerve. However, there's more differences, which is carotid baroreceptors are highly sensitive to small pressure changes. So any small arterial pressure change, there's going to be a faster reaction from the carotid baroreceptor. However, below 50 or 60, it can't be activated because the pressure is too low. It does not need to compensate, and it shows a maximum response around 180. Aortic baroreceptors, however, they're not sensitive. However, they work at less pressure. So if we're at 30, it's still going to be working. And you can also read this also to understand it more if you want. And in here, it basically explains everything I explained in this image. Just know the result of the baroreceptors, of the high pressure baroreceptors, vasodilation of the veins and arterioles, so it's going to decrease our peripheral resistance, and a decrease of heart rate, which is going to decrease our cardiac output. Also, vasodilation of veins is going to also kind of decrease our venous return. Okay, now this was mentioned here, and some people had some confusion in it because it mentions the wording here was arterial baroreceptor system is meant to reduce the minute-by-minute variation in arterial pressure to about 1/3 that would occur if the baroreceptors were absent. So basically what it's saying here, with our baroreceptors, with the nerves, our compensation is going to help keep arterial pressure to 1/3. However, without it, there won't be any compensation, and it's going to there's going to be no compensation, so our arterial pressure is going to constantly stay high. That's basically what it means here in this wording, and you can see here in the graph it basically also explains how does the denervation of veins happen. Okay, now coming to chemoreceptors reflex. Chemoreceptors are also found in the carotid and the aortic arch. However, their function is the opposite of baroreceptors, and they also do not work based on nerves. They work based, they do work based on nerves, however, not based on the stretch or anything like that. It works based on the supply that they're receiving, based on the oxygen supply or any nutrient supply they're receiving. As you can see here, if their oxygen is too low or their carbon dioxide is high, which means oxygen is low, that means we need higher blood flow. We need our arterial pressure to increase. So it's going to do the opposite of what baroreceptors do. And the reflex characteristics, as you can see, I highlighted them in red, which means they're important. The chemoreceptor reflex is weaker than the baroreceptor. Yeah, okay. Although they do the opposite, however, they're weaker than the baroreceptors. It becomes active mainly at low arterial pressure. So if we have high arterial pressure, baroreceptors are going to act up. And if we have low arterial pressure, chemoreceptors are going to act. Now we're going to talk about the stretch of the receptors. This is important. Actually, I'll just read you the function here, and I'm going to explain the next slide because you can understand it better on the next slide. So when blood volume increases, these receptors are activated. They reduce sympathetic activity and promote fluid excretion, helping to stabilize arterial pressure. Here, a concept that gets confused a lot is the difference between SA node and brain bridge reflex. They're not the same thing. Although they both occur at the atriums of the stretching of the atriums, however, they're not the same thing. SA node is the stretching of the SA node itself. So, and an increase of SA node, it's going to have a local response, and it's going to speed up the pacemaker activity. However, in brain bridge reflex, it's going to be the increase of the atrium. However, an increase of the stretching of the atrium or the superior vena cava. However, this can cause a venous congestion. It's going to have like a lot of blood trapped up. So we need arterial pressure to increase. So what is going to happen is going to send this the signals via the vagus nerve, and it's going to then increase sympathetic activity. Now this can be confusing to some people in how does the vagus nerve send signals and then sympathetic activity happens. There's a difference between the vagus nerve being an efferent or an efferent. If the vagus nerve is acting as an efferent, it's always going to be parasympathetic. However, if it was an afferent, it's just sending information to the brain. That doesn't mean it's going to cause sympathetic or parasympathetic activity. And this was an image over here. The doctor gives a summary of everything. Okay, now a question to test also your understanding about what we just talked about. Which of the following statements about the arterial pressure receptors is correct? So A, carotid baroreceptors are highly active even at pressures below 40, which I won't say the answer now so you can test your understanding. Actually, I'll just let you read them first. Okay, and the answer is going to be C. So in C it says carotid baroreceptors show their maximum firing response at near 180, and here it was mentioned over here. Carotid baroreceptors show maximum response around 180, and everything else like contradict each other, all the other options. Now let's talk about the central nervous system ischemic response. Now ischemia, what does ischemia mean? It was mentioned multiple times in other weeks. Ischemia is when the tissues are low on oxygen. It's not receiving the oxygen supply it needs. And this response basically is the last ditch response, is the last final response. It's going to activate when arterial pressure falls below 60, and its maximum activation occurs around 120. So when arterial pressure is so low, and the sake of the ischemic response, central nervous system ischemic response, is to maintain perfusion during life-threatening hypertension. So basically a sympathetic response. We need a very high sympathetic response for us to get all the blood supply we need. And here is I wrote down everything that you need to know about ischemic response. Okay, Cushing reaction. I'm not sure how you read this, but I think it's Cushing reaction. So what happens in Cushing reaction? A Cushing reaction basically is when our cerebrospinal fluid, is increased. And once it's increased, it's going to compress on the brain arteries, because cerebrospinal fluid is mostly found in the brain. And if this increases, if this compression starts reaching the brain arteries, we will need to reduce the cerebral brain flow. We need the blood flow to decrease, because I'm sorry, it's the opposite. If our cerebrospinal fluid is increased and this excess is going to hit our brain arteries, that means our blood flow is low. So we'll need to increase our sympathetic activity as a way to compensate for this. Okay, now this was mentioned in our ECG lab, and we also did it in our ECG lab. What happens when you go from sitting to standing? So when you're sitting down, basically your blood flow is happening normally, everything's happening normally. When you suddenly stand up, due to gravity, the blood is going to go down, it's going to reach down to your feet. So the baroreceptors are not going to be acting up anymore. Where do you find the baroreceptors? It's going to be found in your aortic arch and your carotid. So as soon as the blood goes down, that won't be activating our baroreceptors anymore. So that means our parasympathetic is going to stop. And for a way to compensate, our sympathetic is going to increase. That's why our heart rate starts increasing, as we saw in the lab. And actually, let me read these down. Vasoconstriction increases peripheral resistance and redirects blood flow to vital organs. Increases heart rate and cardiac contractility. Raises cardiac output to maintain adequate cerebral perfusion. Now, Also, our skeletal muscles has a role in our cardiac output and pressure. And how does it have? There's a lot of wording here, so I'm going to simplify the explaining. However, I'll put the Canva template on the description so you can read it later. What happens basically? When our muscles are contracting, our skeletal muscles, or also your abdomen muscles, are going to basically compress on our systemic circulation. And this compression to our systemic circulation is going to increase our venous return and our increased pressure, and this then leads to increasing of cardiac output. Also here, during exercise, the contraction of the skeletal muscle throughout the body compresses nearby blood vessels. So, which means it increases our stroke volume, cardiac output, and arterial pressure. Okay, now coming to local blood flow. I could say no, we basically finished the most important part of the lecture, which was the nervous regulation. Local control of blood flow is also important, but it was like the dense part of the lecture was the nervous regulation. But since now we're done with that, inshallah, local control is going to be a lot easier to understand. So local control, nervous regulation and the blood, it can't supply everything. So we'll need local control for it to also help like compensate for all the parts that still did not receive the blood that it needs or its oxygen that it needs. So we have two types. We have acute and long term. Acute is going to work via vasodilation or vasoconstriction. So let's say a blood vessel is not reaching, it does not have a good amount of oxygen need, is going to vasodilate to increase the blood flow. However, in long term, you could say it mostly acts up based on the metabolic needs of the body. So, and it's gonna, and long term, obviously from the name, it's gonna occur through days, weeks, or months. However, acute control happens while the pressure difference happens. Okay, now another difference that was mentioned is the myogenic and metabolic theory. So what's the difference between myogenic and metabolic? Myogenic is based on the stress contraction response caused by intrinsic property and vascular smooth muscles. Now, if you did not understand this, it's quite similar to the acute, however it's not the same as the acute, but it's similar. It's like if there's any low pressure found in any of the muscles, vasodilation and vasoconstriction is going to happen in order to compensate for this. And we need to know these vasodilators, which is adenosine, carbon dioxide, lactic acid, ADP compounds, histamine, potassium ions, and hydrogen ions. Metabolic theory is based on the delivery of the oxygen reaching certain tissues. So if a certain area is not having the oxygen that it needs, then it's going to local vasodilation is going to happen at that area for the blood to reach that the area that does not have enough oxygen. And here's an image also for it, like basically simplified if you like more visual images rather than words. Okay, now we need to know also the difference between reactive hyperemia and active hyperemia, and this is a really simple concept. Reactive hyperemia is basically you have a vessel, okay, and this vessel you constricted it, okay. So what are we going to have? We're going to have our blood flow decreased, okay. And then once this blockage is stopped, like you let go, it's going to react. As you can see here, it's going to react. And this reaction happens first of all to compensate for the blockage we had earlier, and then it's going to go back to normal. Active hyperemia, for example, when you're exercising, your need for oxygen is going to increase. So vasodilation is going to happen. So as you can see here, your vasodilation is going to increase and your blood flow is going to increase in order to accommodate for the needs of the oxygen that we have. Now, endothelial factors. We took this in F&D, so it should not be that hard to understand. First of all, let's talk about what happens when we have atherosclerosis or hypertension. So atherosclerosis or hypertension, they're both like pathological, which means there's a damage in our endothelial cells. And what we know from past knowledge, the endothelial cells create nitric oxide. So a damage to this is going to impair the synthesis of these nitric oxides, which means our excessive constriction. That means we're going to have excessive constriction rather than vasodilation, which is going to make our case worse. Because during atherosclerosis, we're already not receiving blood. And with nitric oxide not working, that means no vasodilation, which means there's going to be even less blood flow. And the other concept here is sildenafil. Sildenafil is a drug, and fun fact, sildenafil is in Viagra. So what does sildenafil do? It degrades the making of CGMP by PDE5. What does this do basically? This CGMP, it breaks down the creation of nitric oxide. However, if this stops getting made, that means our nitric oxide is going to stay. That means there's going to be more nitric oxide effect happening, which means that our vasodilation is going to last for way longer than it's supposed to be. Okay, now vascular remodeling. I wrote down in here in words. However, I'll explain it to you in a way it's easier understood. Vascular remodeling is when the vessels is gonna remodel itself. It's going to change the way they change how it looks, or like not how it looks, its formation due to any chronic disease that a person has. For example, chronic hypertension. So in chronic hypertension, our vessels are going to become more stiff in a way to like accommodate for the hypertension that the person has. And over here you can also read the outcome. Long-term regulation ensures that the vessel maintain optimal wall stress and efficient blood distribution under varying circulatory conditions. And then humoral regulation of blood flow. You need to know these, because if you don't know them, if we're given any of these, you won't know which one does what. The vasoconstrictors are norepinephrine, epinephrine, angiotensin, vasopressin, and endothelin. These four, you could say, are vasoconstrictors. And for the vasodilator agents are bradykinin, serotonin, histamine, prostaglandin, and nitric oxide. And for ions, an easy way to understand this, all ions do vasodilations besides calcium, and that makes sense because calcium is basically everything that we do to contract our muscles. And this is the last question. Which of the following substances primarily acts as a vasoconstrictor? And from here you can know it's going to be C, norepinephrine, angiotensin 2, and vasopressin. Thank you for watching the video. I'm going to put this PowerPoint in the description in case you want to read through everything or you want to self-study. I believe that the PowerPoint that I made simplifies the lecture that we have and the PowerPoint that we were given a lot more. And thank you.